Hey guys, thanks so much for tuning in this week. I'm Kristen at RMC. This week we have a bit of a different lineup. We have Kandi Williams, who's going to join us again, Dr. Magadia, Whitney, who is one of our ICU nurses, and Chris McGowan, who is over our ER department. So if you have questions, please comment them below. We will get to them this week. And if we don't get to them, we'll try to reach out after this. So without further ado, here is Kandi Williams. Thanks.
Okay, good afternoon, everybody. So I have some general numbers for you guys to share from the hospital perspective. These numbers were from this morning, so they may be a little off, but they are still as accurate as possible. As of this morning, we had 70 total inpatients. That's 70 total inpatients with an addition of 18 in the ER. So that's a total of 88 patients that we are providing care for that are COVID patients. 54 are medical. 16 are ICU, and of those 16, 15 are on ventilators. We, as of this morning, had 18 in the ER, 16 were medical, and 2 were ICU. Chris may come on in a moment and give you some more updated numbers, but that is what we had as of this morning. So, let's talk about vaccine status. Of those patients, of those 70 inpatients, only 57 did not have a vaccine. So, 83% of our patients are unvaccinated. What does that mean? It means the vaccine's working. So the rest of the patients are fully vaccinated or unvaccinated. If you take anything away from this today, know that vaccines work, okay? 83% of our patients, again, are unvaccinated. It does not matter to the care we provide the patient, but what we want to try to get across to you is if you're vaccinated, you're not here with us, and that's the goal, okay? The age range of these patients are 25 to 91. Our average age is 60 years old. Looking at the month of August, we had a total of 206 admissions and 37 deaths. Our youngest death was 29 years old, and our oldest death was 94 years old. So far, month to date for September, we've already have 11 people that have passed away. If you do not require emergent care, we ask that you please do not come to our emergency room. Our emergency rooms are operating beyond max capacity at both RMC and Stringfellow. We are doing our absolute best to provide care to the patients that are here, but we ask that if you are not emergent, that you go to your own primary care physician or to an urgent care in the community. If you do need to come here, expect long waits, but know that we are prioritizing patients based on their need and how they need to be treated, okay? The easiest way to prevent becoming a statistic, again, is to get vaccinated. We know that vaccines save lives. Vaccines are not going to necessarily keep you from getting the virus, especially if you were vaccinated early in the spring. We see that those vaccines are starting to not be as effective. However, we do know that we're going to start doing boosters in the future, and we'll have more information on that as it becomes available. So, get vaccinated. If you want to be here to see Thanksgiving and Christmas, the best advice we can give you is to get vaccinated. Our vaccines that we provide through the hospital are every Thursday and Friday. Thursday, we provide Moderna vaccines from 8 a.m. to 10 a.m. in the Tyler Center, 4th floor RMC Wellness. On Fridays, we provide Pfizer from 8 a.m. to 10 a.m. in the 4th floor Tyler Wellness. So when you come to the Tyler Center, you'll go up the elevator to the 4th floor, take a left. We will be in that clinic providing vaccines. You do not need an appointment. Again, anyone between the ages of 12 and 18 have to take Pfizer. Anybody above 18 can take Moderna or Pfizer. We're also providing antibodies, the monoclonal antibodies, at the 10th Street Elementary School. We began that last week. We have been able to accommodate up to 80 patients a day, which is big, and we're very proud of that. We're able to help take care of these patients so that hopefully they don't end up in the hospital. If you feel like you need antibodies, please contact your physician or an urgent care where they can assess you and see if you meet the criteria for antibodies. Not everybody is a candidate for antibodies, and so that's why we require a physician order. So if you will contact them, if they feel like you need it, they will send the order over and we will get you set up for an appointment. If not that day, within the next day or two, we'll try to get you in as soon as possible. Again, if you take anything away from what we're saying here today, the hospital is beyond max capacity. We're providing care to everybody that we absolutely can, but we need you to get vaccinated. We need you to stay home with your families and take care of yourselves. Wear your mask. Be careful because COVID is not getting better. It's only getting worse. Thank you.
Good afternoon. I'm Dr. Magadia. I'm the infectious disease specialist. I'm the chairman of infection control and the director of the pandemic unit. I'm going to be talking about a few things today, specifically the antibody testing. I have been asked multiple times about the utility or lack of antibody testing as far as immunity is concerned. So I'm going to dwell on that. But before that, I'm going to announce today that Stringfellow has 8 COVID patients in that hospital, and they have been sitting for the past several days in their ER. So their ER are kind of inundated with this COVID patients. So as of, I think, tonight or tomorrow morning, they're planning to open their own COVID ward. That COVID ward could accommodate about 12 patients. It used to house their detox unit. So we're going to be working with them as well. RMC is still the main COVID center here in this town, but it's since we have been seeing a lot of patients sitting in the ER, both hospitals, they have decided on their own to make their own COVID ward. So it's really a great resource for us. So dwelling on the antibody testing by serology, so before you guys go to sleep, I'm going to talk about basic immunology. Like I've said before, I'm an infectious disease specialist, but my department at Rutgers is actually formerly called Division of Allergy, Immunology, and Infectious Disease. So we have in our staff allergologists and immunologists. And, immunology is one of those specialties, topics that you either love or you hate. I kind of am in the middle. There's a lot. It's a fascinating field. But going back to the antibody testing with COVID, the commercially available antibody testings that you could get, LabCorp Quest or any laboratory, specifically tests for one antibody called binding antibodies. And I have a show and tell here. So you have 2 antibodies. One is called binding antibodies, or they are otherwise known as receptor binding domain. This is the one that those commercially available antibody testings report. There's one that you actually want called neutralizing antibody. These testings are not commercially available yet. So the difference between the two, the binding antibodies, they check for the exposure. It does not really tell you whether they're immune or not. The neutralizing antibody, if you could get hold of a neutralizing antibody titer, that will tell you that if they're immune, because this is the one that will kill, these antibodies will kill the SARS-CoV-2 virus itself. The binding antibodies will tell you that they got latched on. If you remember your basic immunology, antibodies, either IgA, IgM, IgA, they're shaped like a Y. So the main frame is the body itself, but the Y there, those 2 kind of horns, they're the places where the antigens, in this case SARS-CoV-2, kind of latch on. So the binding antibodies, they're right around here. So your SARS-CoV-2 will latch onto them, but the action really happens in this guy, the neutralizing antibody. So the neutralizing antibodies will kill the SARS-CoV-2, which the binding antibody latch onto. So these commercially available antibody testings do not really tell you, other than, they have been exposed, but they do not tell you that they're immune to it. My society, Infectious Disease Society of America, published some kind of guidelines on antibody testing back in August of last year, and they modified that about 5 days ago on 9/3, September the 3rd, and they said there's only 3 clinical scenarios by which you would order antibody testings. So this is for the primary care physicians watching this. Only 3 clinical scenarios. One is if you have a patient, they've been sick for about more than 2 weeks, they have had multiple negative PCR testings or molecular testings, but they talk, they walk, They sound like a duck. It looks like COVID, but multiple testing have been negative. But you have to confirm either because the patient wants it for their peace of mind. It's warranted to do an antibody testing, but antibody testing does not substitute for PCR or a swab, whether it's an antigen testing or a molecular testing or rapid testing. You still have to confirm it. The second scenario by which you could order an antibody testing is a condition, especially in kids, called MISC. MISC. It stands for multi-system inflammatory syndrome in children, wherein they get rash, they get muscle aches, they get conjunctivitis, they get some kind of cardiac manifestation. So it's a variety of symptoms with kids. So you could order that. And thirdly, you could order this antibody testing if they're part of a zero survey, meaning if you're a facility, whether a health department or some kind of entity, they're doing a zero surveillance study, meaning for epidemiological purposes, they want to know how many in the population, the particular population, have had the COVID or have been exposed to SARS-CoV-2. Outside of those three clinical scenarios, it's not really advised, at least by my society, Infectious Disease Society of America, to get antibody testing. It's $50 that you burn. That's not really reliable. Case in point, I have been asked multiple times about, hey, I got a shot back in March or April, and I recently had an antibody testing, and my antibodies are through the roof, so I don't really have to wear a mask. Not necessarily true, because they're only testing for the binding antibodies. They're only testing for the receptor binding domain. They're not testing for the neutralizing antibodies. So those people who claim that they have high titers, they still have to wear a mask. They have to do those things that we all talk about, WWW. Wear your mask, wash your hands, and watch your distance. And there's another one called V. So WWWV. Wash your hands, wear your mask, watch your distance, and V, vaccinate. All right, so that's it for me. I'm going to be handing the floor to a person who's new to our team. She had been an ICU nurse since 2015, and she's joining us, actually joining me specifically as a nurse practitioner, which she has been for the past 3-4 months. So today's her first day. She's going to be a great resource for a lot of people. I'm not allowed to say her phone number, but you could contact her. She's actually willing to take my call. She actually told me this morning, that some nights she might take my calls at 2 o'clock in the morning. So I did not record that conversation, but I'm going to take her up on her offer. Her name is Whitney Watson. She had been a great ICU nurse for us, and I'm going to leave the floor to her. Thank you.
Well, thank you for that great introduction, Dr. Magadia. Hi, my name is Whitney Watson. I have been a nurse for about a decade. I did both my bachelor's and my master's, my nurse practitioner degree at JSU, and I live with my family here in the Anniston community. My career, I've primarily worked in critical care roles, both at UAB, and then I came back home here to RMC in September of 2018. As part of the ICU team, I've been on the front line of this pandemic since the beginning, back in February of 2020 when we really started seeing patients. And it hasn't been easy. These patients are very sick, they're critically ill, they're on multiple drips. And transitioning to a new role as a nurse practitioner, I didn't feel like that was a fight that I was ready to give up. I'm very dedicated to this team, and I'm very dedicated to helping our community fight against COVID-19. So I'm very proud to join Dr. Magadia in this new role as nurse practitioner, and I hope that I can be an asset to the infectious disease team and to my community. So thank you so much.
I'm Chris. I'm the nurse manager in the emergency department. Just to put some things into perspective about how the ED is functioning during all of this, you kind of have to think about what we were doing before. So typically our ER can accommodate 34 beds. That's beds with monitors that we can put patients in to have the desired patient experience of being seen in a bed. In the situation we're having right now, we've been averaging between 40 and 60 patients in the department consistently for the last couple of weeks. Some of those are admission holds. So this morning we had about 22 patients holding in the ER. So that's 22 out of our 34 beds that are taken by admitted patients, which slows us down from the ED side of things, being able to see new patients. Our volumes are still as high. We're still seeing other things besides COVID. We're still getting heart attacks, strokes. We're still seeing gunshot wounds. We're still seeing normal ER patients on top of the COVID surge. It seems like the COVID admissions are kind of becoming more than our regular medical admissions over the past week or so. We've definitely seen a trend towards that where we're holding more COVID patients. One thing that we've done, we've increased our staffing in the department. Typically, our bed availability after 11 p.m. goes down to 18 beds. And when you have averaging 20 holds, it just doesn't work. So we've increased that so we can accommodate more holds throughout the night. And so most of our staff, we are tired. Most of our staff is working extra, picking up extra shifts. Another thing we're doing, if you come into the department, we're working a lot on vertical movement of patients. So instead of going straight to a bed, you may be seen by a provider either in the lobby to get things started. They can order workups, and if something comes back critical that we need to address, we use that as like a secondary triage so we can get you put in a bed so we can get you seen quicker. But if there's a lot of patients that we can do complete workups, whether it's a CAT scan, x-rays, lab work, have those resulted with you still being in the lobby, and we can disposition you from there. That's just kind of the nature of the beast right now with all of the admission holds. Last thing is EMS. So the EMS service is overloaded as well. They're having longer wait times because of the overwhelming amount of COVID patients we are seeing. So that's one thing to consider, coming to the emergency department to have a COVID swab by EMS is not a reason to call an ambulance and take an ambulance out of service. The stress is on the entire health system, so anything we can do to alleviate any of it is greatly helpful. About testing, the facility, we're actually running a little low on the swabs that we can run. So we've been doing more send-out testing. However, if you're coming to get cleared to go back to work just to have a COVID swab, the emergency department is not the place for it. The health department or other places in the community can offer testing. And honestly, if you're coming for a test, whether you're symptomatic or not, you may not leave with a positive result. Our wait times are higher than normal for both COVID and non-COVID patients. We're about split in half between regular patients and then COVID patients. So triage is a key. What we're doing, the sickest patients are in, the beds. So if you have an oxygen requirement, an oxygen demand, that will get you in a bed quicker than what you normally would be put in a bed for, because we can't use oxygen in places where we're keeping patients. Another thing to consider that goes on in the ER that people don't see, so we've held COVID patients on ventilators for 2 to 3 days in the ER. So one thing with that is, we can't put a ventilator in any room, so we have to move these patients around somewhat. So if you're coming in and you're sick with COVID, one thing that we're kind of asking to do is to leave your belongings at home. If not, our security department here can lock those up for you and keep them safe until somebody else can pick them up. But if you could leave most of your belongings at home that aren't necessary for the stay, that would be greatly helpful for the facility in general. We are trying every day, with administration, our physicians are working on plans. Every day is a new challenge, and we seem so far to have come up with another plan to make things work, whether it be in the ER or upstairs. We have a great team, and our primary goal is to take care of the community. So all these changes is just to be able to see more patients. And that's the goal. That doesn't mean the emergency department system can be abused with, people just coming for a swab. If you're symptomatic, sure. we can lay eyes on you, but there are no swabs promised. So positive results or negative results the day you're seen in the ER.
Thank you, team. There's a question regarding the flu, which is a little bit appropriate because the flu season is upon us. I think there's some facilities now offering the flu shot. We are not offering it yet. Hopefully in the next 1 or 2 weeks we will be getting that. But the specific question was what are our flu numbers pre-pandemic and our flu numbers last year, the full year of last year. So what I could tell you is our flu numbers in 2019 pre-pandemic, we had 292 patients with the flu needing to be hospitalized. So these are patients who really got sick to the point that they ended up in the emergency room and subsequently got admitted for a variety of reasons, foremost of which is dehydration, inability to take anything oral. Some of them might have ended up with concomitant superimposed bacterial infection. So that was 292 in 2019. The whole of last year, in December of last year, we had 8. We had 8 patients that had to be hospitalized with the flu. So from 292, it went down to 8. And a lot of things happened. Obviously, the pandemic happened. But we told everybody to wear a mask. That's really a case, textbook case that wearing mask and masking work. Also, we, in the summer of last year, we were telling everybody that this is going to be bad, this is going to be bad. You have to get your flu shot. You have to get the flu shot. Most of them heeded our advice, so they had their flu shot. A lot of people also shut down. They did not work, or they work remotely at home. So social distancing works. So that really tells us these numbers, from 292 in 2019 to 8 patients in-house with the flu in 2020 really tell us that, the masking work, social distancing work, and vaccines work. Any other questions?
One from Grayson Gibbs. After being tested positive for COVID, how long do you have to wait before getting vaccinated?
Okay, so the question about the timing is a little bit tricky because it has changed. Pre-Delta, they said that if you have had COVID, your antibodies last for about 90 days. So that means you could opt for not getting vaccinated for at least 3 months. That was pre-Delta. Delta happened in June, July, so that kind of recommendation changed. And now we're telling our patients, admitted patients, and even patients in the office that if you have had COVID, you wait 4 weeks or a month. So because that particular strain that you've had with the COVID might not protect you against different strain, either the Delta or I'm not gonna say the M strain, the mu strain, because it's bad. But it's 4 weeks.
Another question regarding the antibodies treatment, regarding the number of days from onset of symptoms until you're allowed to have antibodies. How many days? Is it 7 or 10 days?
10 days. 10 days. Which also dovetails me to monoclonal antibody. If you had COVID and you have gotten monoclonal antibody, the wait for vaccination is not 4 weeks, it's 90 days. So we revert back because the monoclonal antibody that you got, either IV or sub-Q, offers you a longer immunity, at least another 2 months, so 90 days for that.
Have you had any of the new variants, and is this vaccine covering the variants?
So we don't have genomic sequencing assay capability. We have PCR machine. So we do the molecular testing. We have the rapid testing called Sophia, but we don't have capability of doing a genomic sequencing assay, which will tell us the variants or the mutation, which will tell us whether it's Delta, Mu, alpha, beta, theta. So we don't have that. So based on based on testing by CDC and Mayo Clinic, about 93% of circulating strains in the United States right now is Delta. So the treatment is kind of the same anyway, whether they have Delta, Alpha, or the wild type strain. You're getting the same treatment. It's just that they manifest kind of differently in a way of the incubation period is much faster. So we currently don't have somebody that we say they're Delta or Mu or Alpha or Lambda right now. So we're testing, we're doing the PCR, but we don't really test them for the variant strains.
Have recommendations changed for vaccinated people exposed to COVID?
So the exposure it has not really changed much. If you were exposed and you think that you're getting symptomatic, obviously you have to wait and get tested. On day 3 or day 4, and then if you're positive, wait 4 weeks. If you have been asymptomatic the whole time, whether you got tested or not, it's still the same recommendation when to get vaccinated. They have not changed.
You already answered, but someone else asked, does this vaccine cover the new variant?
So we think the variant strains, including specifically the Delta and the Alpha and the Beta, the currently available vaccines in the United States, Pfizer, Moderna, which use mRNA platform, and the J&J, which use the vector virus, adenovirus platform, they have some coverage against the Delta strains and Alpha and Beta, not at the same level as protection against the wild type strain, the original strain, but you are protected. There's a new strain circulating. I'm sure you've heard that on lay media about this MU or Mu strain, which might be resistant to the currently available vaccines. Fortunately, though, it's just a variant of interest right now. It's not really a variant of concern based on CDC and WHO. So they're not really prevalent right now. I think it's less than 1%. So right now, the predominant strain is still Delta, which is about 93-94%.
What are symptoms in children?
So as a disclosure, I don't really see kids. I try not to see kids. So I'm not board certified to do kids, but based on the readings that I get, is pretty much almost the same symptoms. They get fevers, they get chills, they might lose their taste or smell. But there's a specific condition in kids called MIS-C, and I kind of alluded that earlier. Multi-system inflammatory syndrome in children, when they get rash, they get conjunctivitis, which you rarely see in adults. They get muscle aches. So there's a lot of things. That's why it's called multi-system inflammation in children. So they might be different in that way, but for the most part, they get runny nose. They get maybe a sore throat. There's a kid that I was involved with that the only symptom was headache, and kids don't have headache. They just don't have headache.
We'll take a few more questions. If you tested positive on Thursday and have no symptoms today, do you still quarantine? And also, can symptoms still show up? When will you test negative?
So it depends on your strain. So if the strain that you're talking about is the wild type of the original strain, the incubation period is somewhere from 1 to 15 days. The median is about 7 to 8 days. So between day 1 to day 14 or day 15, you could have symptoms there. The Delta strain is a little bit trickier because the incubation period is much shorter. So it's about 3 to 5 days. So if you got, and there's no way of knowing whether you got the variant strain, Delta strain, or the wild type strain. So it's kind of hard to tell. So I just go by with day 15. So if you don't, if you got exposed on day 0 and you don't have any symptoms all the way to day 15, you're probably not going to have symptoms ever, unless you get re-exposed.
On that note, why are some people testing negative but still have all of the symptoms?
Yeah, so it depends on the platform that they're using. It depends on the testing. So the rapid antigen testing might not be as accurate as the PCR, which is the gold standard, about 98-99%. So there's not much false negative in PCR compared to those rapid testings that even the home kits that you do almost like a pregnancy test, because they're not DNA, they're not RNA platform, they're not PCR. So it depends on what platform, it depends on what testing you do, but there is such a thing. There's no test that's 100% accurate. Even the PCR, they're not 100%. So you could have false negative and false positive depending on somebody's immune system, somebody's exposure, or the inoculum, or how much virus they inhaled, and all those things. So it's kind of hard to delineate those because people are different, and testingers are different.
Here's a good question. Washing someone's laundry, how long should you let your clothes sit out before you wash them if they were on someone that was positive for COVID?
Oh, wow. I don't think I've been asked that question before. I don't think there's a guideline from CDC on that. I think we know from last year that they don't really last on fomites or non-viable things like chairs and clothes and things like that. So I would recommend that same thing that you do for your any other clothes, but you might want to crank up the heat on the dryer if they're exposed.
One more question. Is it recommended that you get the booster no matter your health?
Okay. So we kind of addressed this about 2-3 weeks ago. So outside of the 6 groups that CDC, FDA recommend to get a booster right now, as long as they have gotten their booster 4 weeks earlier, and those 6 groups are transplant, cancer getting chemo, HIV/AIDS, immune deficiency, patients getting biologic, and patient getting a specific antigen called CAR-T therapy for some kind of blood cancer. Outside of the 6 groups, we do not recommend that you get your booster shot right now. It might come in about 2 or 3 weeks, the end of September, especially those who got their second dose in mid to late January of this year. So that's 8 months. So it's gonna happen in about 2 or 3 weeks. But please wait another 2 weeks. If you're not on that six groups, do not have a booster shot right now, because it really impairs our ability to reach out to a lot of people. There's a science behind that recommendation. There's some trials behind that information. So if you go and jump the line, I mean, it's not bad, but it's kind of morally and ethically wrong because you're jumping the line. So we don't recommend. I have not gotten my booster. I'm waiting for my 8th month, which would be the end of this month.
That's all our questions right now. I'll wrap this up.
Vaccinate.
I'll cover a few things. All right, just to wrap us up, I wanted to summarize what all we've covered. If you still have questions about how to get tested, how to get your vaccine, or questions about the monoclonal antibodies treatment, we have a page on our website. Go to rmccares.org. We've got a drop down on coronavirus information, and you can click any of the pages on testing, vaccines, or monoclonal antibodies. And for the antibodies treatment, we did a great video with Dr. Bohannon, who answers a lot of questions about what it is, who's eligible, and all sorts of things. Again, if we didn't cover your questions, please leave them below and we'll try to get to you. Tune in next week. We have a weekly checkup on Tuesday with Dr. Alicia Evans. She's one of our new family practice doctors. She's at Oxford Family Practice. And then on Wednesday, we'll have another weekly update. So join us then. Thanks.